Well, good evening, everyone, and we would like to thank all of you for watching the documentary FAUCI. Let us start the evening by thanking Picture Motion and National Geographic for graciously allowing us to have this virtual screening. This event is brought to you by the Greater Palm Springs chapter of the Association of Nurses in AIDS Care, otherwise known as ANAC. ANAC is a nonprofit nursing organization committed to fostering the individual and collective professional development of nurses involved in the healthcare of persons living with or affected by HIV. The Greater Palm Springs chapter of ANAC was founded in 2018 and is comprised of nurses, physicians, pharmacists, social workers, and other healthcare professionals working to support HIV prevention and HIV/AIDS care across the Coachella Valley and beyond. The Greater Palm Springs chapter funds education and scholarships and hosts researchers, clinicians, and experts in the field of HIV and healthcare. Thank you to the Association of Nurses in AIDS Care, Greater Palm Springs chapter Board of Directors, Anthony Velasco, President, Jody Kapp, President-elect, Shelley Baxter, Secretary, and Rebecca Sandlin, Treasurer, for sponsoring this event. Would also like to thank DAP Health for collaborating and bringing you this panel discussion. A special thanks to Sue Lowe and Anthony Velasco for producing our virtual screening and virtual panel tonight. My name is Jimmie Leckliter, and I will be moderating our event this evening. I have been a nurse for over 10 years, practicing in the areas of correctional HIV care and neurotrauma emergency medicine. Currently, I serve as a nursing instructor for 2 local colleges here in the Coachella Valley, where I'm able to share my passion, experience, and knowledge of the nursing profession. I am one of the 4 original founding board members of the Greater Palm Springs chapter of ANAC, and I currently serve as the chair-elect for the nominating committee. I am also a member of the policy committee at the national level. This evening, we are blessed to be joined by a diverse group of panelists. First, I'd like to introduce Ms. Bridget Piku, who is a licensed vocational nurse in Palm Springs, California. Bridget, finding a nurse voice in advocacy and activism is a natural progression, since she feels that every time she fights for someone else, it affirms her own life. She is the incoming president-elect of the Association of Nurses in AIDS Care, Greater Palm Springs chapter. She also uses her voice to speak for others on the board of directors for HARP PS, an HIV aging research project, and as a community advisory board member for the WELL Project, HIV and Women. Bridget also pens a column for Positively Aware magazine called Being Bridget. I'd also like to introduce Ms. Tulika Singh, who is a board-certified HIV specialist, infectious disease, and internal medicine physician, and has been working in HIV care since 2009. Dr. Singh received her medical degree from Kasturba Medical College in Manipal, India, and completed her internal medicine residency and chief residency at St. Elizabeth Health Center, Ohio. She then went on to specialize in infectious disease and HIV from Medical College of Wisconsin. Currently, Dr. Singh is the Director of Research and Associate Chief Medical Officer at the DAP Health, where her focuses are bettering patient care and mentoring those around her. Dr. Singh continues to strive towards new and innovative ideas by actively working in the field of HIV and aging research to help address and improve current health issues. She co-wrote HIV Primary Care Guidance for HIV-MA IDSA in 2020 and continues to publish her research in various AIDS journals to promote cutting-edge IV therapy. We are also joined by Dr. Shubha Kerkar, who completed her medical school in India and completed her internship, residency, training, and fellowship in infectious disease in Philadelphia at the start of the HIV/AIDS epidemic. Inspired by outstanding mentors in infectious disease, she wanted to be in infectious disease doing everything with culture and sensitivity, literally. She has been highly involved in HIV, hepatitis B and C, SARS, MERS, and COVID-19. All of these conditions all have underlying and other non-infectious conditions such as opioid use disorder, mental health issues, inequality, and discrimination that we need to address. And finally, we are pleased to have Dr. Christopher Fultz. He is originally from the Midwest. Dr. Foltz completed his internal medicine training at Cedars-Sinai, Los Angeles in 2015, followed by infectious disease training at UCLA in Los Angeles in 2017. He came to the desert in September of 2017 when he joined Desert AIDS Project as a full-time staff physician. His clinical interests include general HIV care, general infectious disease, and transplant infectious disease. We are blessed and very gracious to have all of you with us tonight, and thank you for your time. We will start off with questions for our panel. For our audience, if you have questions, please feel free to type them out in the chat section and specify which panelist, if any, the question's for. If we are unable to answer all the questions tonight, please feel free to email gpsanac@gmail.com, and I will be happy to get all of your questions answered. Let's see. Okay, so for all of our panelists, I'd like to say, what was your takeaway from the movie? So Dr. Fauci has been significantly involved in various epidemics, including from the very beginning of HIV and now COVID. As he mentioned in the movie, it was like bookends to his career, as he says. What are some of the parallels with two epidemics, and what do you think we learned from handling of the AIDS epidemic that has aided us in the current COVID crisis? I'd like to start with Dr. Singh.
So no one prepared us for COVID. We have three very trained infectious disease MDs here. Dr. Kerkar, decades of experience. Myself, yes, over a decade, and Chris is pretty close too. No one prepared us for COVID. No one prepared anybody for COVID. HIV, we were lucky that we had a lot of already a lot of education and a lot of work already done for us to be able to learn the art of HIV pretty well and be able to help our patients. So it's almost like we have a PhD in HIV and then nothing in COVID, and we all learned about it together. So that's the best way I can put it. And I'll let the other panelists have their take on it.
That's a wonderful analogy, Dr. Singh. Thank you so much. Dr. Foltz, how do you feel the HIV epidemic prepared us for what we're experiencing today with COVID?
Yeah, I mean, I think the movie highlights a couple important, I guess, similarities between the two. So, I'd say one is kind of like just the nature of the fear. So I thought that was a big thing, how similar the public response was to an unknown. And, we as clinicians and scientists and stuff too, were kind of in that same realm. We didn't really know much about COVID. We were racing to get answers. And then, at the same time, I was running a COVID clinic and doing interviews and stuff with information coming in literally minutes, hours before, sometimes we had to talk. So, that I would say is much different than back then where, information exchange and stuff was a little bit slower, which was probably good and bad for different various things. You can kind of see the two parallels between the two epidemics just with that alone. And then the science too, that I would say was pretty similar in the sense that, when HIV first started, we didn't even know what it was. We didn't know it was a virus. We didn't know it was spreading. And COVID, in a way, granted, we figured this stuff out in days to weeks compared to years like it was back in the 80s. But, just the change and the shift and how quickly how the science can evolve. I think one part of the movie they mentioned, he was sitting looking at a PowerPoint. As soon as they got the DNA sequence, they could make that vaccine like in days. And like just the science, to see the science come that far in just 20, 30 years is pretty remarkable.
Wonderful, thank you. And Dr. Kerkar, I know you're having some technical difficulties, and that's okay. How do you think that the HIV epidemic prepared us to handle the COVID epidemic that we're experiencing today, if there was any benefits at all?
I'm so sorry, my video stopped working, and I'm not sure I'm able to put it on. I'll try in between. But to answer your question about how the AIDS epidemic prepared us for COVID is a really important one. You have to remember that COVID, what happened with in 10 months, the number of deaths and all the roller coaster issues of, deciding where this virus is coming from, why it's killing so many people. The common themes were the lessons that we learned from AIDS epidemic was to really disseminate information as we became aware of it, to calm fears and to deal with all the issues involved in caring for patients and hopefully stopping deaths. But it was as if we were on a roller coaster ride trying to fix the wheels of the roller coaster while we were riding on it. It was too fast. What happened in 10 years, number of deaths in 10 years with the AIDS epidemic were compressed in, say, 10 months of 2020 with the COVID. So I think the lessons we learned had to be deployed in an urgent manner more than any other way. So
and then Dr. Fultz had kind of made that analogy comparing, the technologies and how, today we have social media and this quick way to get information, where back in the beginning of HIV, it could take, weeks, months, or a year to get any information. So as you're saying, what took 10 years for HIV has only taken us 10 months for COVID. And I think that's a wonderful plus and a minus at the same time. There you are. We can see you, Dr. Kerkar. Bridget, how would you say from a nursing perspective that the two pandemics, if there's any parallels or similarities?
So for me, I definitely see the parallels, like Dr. Fultz was saying, with the fear, and also hearing from patients about feeling the same kind of isolation and loneliness that they felt in the beginning of the AIDS epidemic, now with COVID. But one of the takeaways that I got from the movie for me on the more positive side is that towards the end of the movie and the documentary, particularly during the conference when Dr. Fauci was kind of comparing the two sides between the activists and the scientists. And I think from that, we've kind of learned to approach things now as a human kind of process, as opposed to just being a disease process. And so that was my major takeaway, and I hope that other people feel that way too.
Perfect. Well, thank you so much. As we all know, today is December 1st, which is World AIDS Day. And the theme this year is ending the HIV epidemic, equitable access, everyone's voice. What does equitable mean to you? And how can we as healthcare professionals make our healthcare system more equitable and inclusionary? And Dr. Foltz. Oh, you need to unmute yourself, sir. There we go.
Yeah, I think, it really comes, equitable really should mean equal, meaning, and I think here in the United States, we're definitely very jaded. And I think there was a good part of the movie that showed the difference just here in the US versus the world, and kind of how HIV was, not thought of really as a global problem. And until they really thought of it as a global problem, and we thought of it, and we faced it like that, it was never going to be a solution for anybody. And I think that's really the takeaway here is for these, we have therapies that work. We know that, the issue is getting them where they're needed, getting them cheap and affordable to where we can get them access to everybody. Getting preventative measures out there, all this stuff we're doing, but we're definitely not, look, we're 30 years later, still fighting this fight. And yes, we've made it significant headway, but we still have a long way to go. And I think probably the future is the way we deliver meds. And in my personal opinion, like I said, these meds aren't going to get much better. There's some subtle differences, but they all work now. So it's now about getting them to people and getting them in creative ways, so that, we don't have to worry about people taking pills every day or longer acting formulations. All of these, I think, is the future. And that's really kind of where a lot of the research is going to ultimately, this is how we're going to get to a cure, is once we can get everybody treated, get everyone undetectable, get everyone on PrEP who needs to be. And we're still a long ways away from that. But, even in, my 5 years almost at DAP, we've made headway, at least here locally, in significant ways, not only with HIV, but with other infectious diseases as well.
Wonderful. Bridget, how would you say, in your thoughts, and again, a great nursing perspective of what equitable and inclusionary means to you? And I think this is wonderful because, we just came back from Washington, D.C.'s conference, and you were on the DEI conference committee. So I think that'd be wonderful to hear maybe what they're sharing as well.
Yeah, I think, equitable is a little bit different for everyone, depending on, cultural background and socioeconomic background. But at the end of the day, it means that whether I live high on a hill or low on a mountain, I can walk into a doctor's office and get the same kind of care that the next person gets, that it is whole person centered care. And they're treating me as a whole and not just my disease process or what they consider to be my risk factors are. Because, if HIV hasn't taught us anything, it's taught us that people who don't think that they're vulnerable to a certain disease or a certain disease process are. And so equitably speaking, we have to look at the whole person and treat the whole person, despite ageism and sexism and homophobia and stigma. Like, all of those things have to be taken into consideration, and we have to level the playing field amongst the whole patient population so that everyone gets the same care.
Exactly. Now, I think, Dr. Kerkar, I'm going to come to you next, and I think you're going to have a very unique perspective on what equitable and inclusionary means, because you've been doing this from the very beginning. So I think you have seen some wonderful, maybe not so wonderful changes through HIV. So your perspective, I think, is going to be wonderful.
Yeah, I think, the most important lesson, I'm so sorry. Most important lesson is that nobody is safe until everybody is safe everywhere. And we're talking global. HIV and AIDS pandemic was global, and so is COVID. And initially, the issues were, it's only a gay disease, or it's only for drug addicts. And then we had more information that it doesn't discriminate. It can affect anyone. It can affect by affecting your loved ones. Practically almost everyone on this earth is affected. And so equitable means that you deliver the best to everyone within your reach. So whoever you touch, that person probably could touch others. And so I think it would become infectious if we had that sentiment when we were caring for individual patients, because you may actually send a ripple effect. So the part of equitable is, so well demonstrated through the last 40 years now. But it has many barriers, and barriers have never gone away. Just like Bridget mentioned, these things about race, religion, your political beliefs, your everything has been a barrier, and it's been there before. But how did we win the wars, or how did we win or get ahead, if I could say that, for the AIDS epidemic? We have forgotten how it had been, and watching the movie actually reminded me of so many things that I had completely chosen to forget because we had moved on. But then painfully we were reminded of this new virus with new set of individuals it was attacking. But ultimately we realized that everyone is affected. So I think, we're trying to stretch over 40 years what we have learned, and we're still not anywhere, because now our barriers and challenges are even more because of the social media, and anyone can express anything without any basis.
Right.
And can mislead, can create confusion. So it is harder to win trust. It is harder to win faith into science. And we want to be able to create an environment where we can believe in something that gives us meaningful information, and then we can disseminate. But I think, there has been much harder challenges due to more information that is misleading and sometimes confusing.
Correct. I think, listening to each of your individual comments, I think a piece that really is important about moving forward with equitable and inclusionary care is collaboration. In the film, some of the AIDS survivors say they felt that Dr. Fauci was not doing enough to prevent the rapid deaths of those who had contracted HIV. Now, do you believe it's important that the scientists and healthcare professionals engage with the community affected by a disease when creating treatments? And if so, yes or no? And in what way do you think healthcare professionals or government agencies can collaborate with these affected communities? I mean, as Dr. Kerkar was saying, at first it was thought to just be a gay disease, and then we found that it affects everyone. And COVID came out, and there was not one single demographic. It was hitting everyone and anyone. So we'll start with Dr. Singh. What is your thoughts on having those that are affected with a certain illness participate in panels or studies to create treatments?
That was one of the major takeaways for me from the movie, actually. That was the answer to my first question, actually. What was important to me when I saw that in the movie, where at some point Dr. Fauci realizes that all this work that he's doing in his lab in NIH and with this whole team and all this money going in the research for HIV, it meant nothing to patients who were actually suffering, patients who were actually experiencing death and disease, did not care what was going on in that one lab. And for Dr. Fauci and his team to, I think he put 14, 16, 18-hour days at one point during the research, and they are working so hard. And they don't understand why it's not being appreciated or even acknowledged by the patients who were dying of AIDS. So as a researcher myself, I have experienced this and guilty. Sometimes we get so in our own path of following the research protocols and make sure we're doing all the steps and the documentation is being done and everything is being done like it's supposed to, forgetting to almost ask the patient like, hey, do you think we should even be doing this type of research? Is this even gonna help the community? Luckily for me, I had done a little bit of thinking about before I started doing research, and my major passion topic is HIV and aging, and we do serve that population at DAP and in the community. So I did pick that topic after thinking, but I definitely feel we have a client advisory board at DAP Health, and we do appreciate feedback from them. And when it comes to discussing research, upcoming research collaboration, absolutely. Knowing who to help and why to help them is as important as following a protocol and being able to do that well. So I really feel the collaboration is the most important thing, because someone who's living it on a daily basis versus someone who's seeing it from outside and trying to control or create something that will help them will not have the same perspective as someone who's this is their life. So
wonderful. You know, and in research, so Dr. Foltz, there's been some advances in HIV care. So in the past 4 decades, there has been significant advances, and you were talking about how, you know, the meds that we have now, they're working, and we're looking towards longer treatments or maybe less pills, or now I know there's these medications, you can get injections now that last for a month. Are you able to share with us any other or any new up and coming medications and treatments that we should be aware of as a community?
Yeah, I mean, there are still some new medications or new classes of medications in the pipeline, but I would say when it comes to the actual treatment of HIV, we pretty much figured it out, meaning our medicines are fairly well tolerated, they work very well, very effectively, and they do their job, meaning they get people suppressed and they'll keep them that way. The issue that's always been the problem is the need to take a daily pill, I would say, or since, you know, the latest kind of technology with HIV, once we got to the triple regimens in a single pill, now pills are almost the wave of the past. You know, we're now looking at, if that's our problem, making sure someone to take a pill every day, how can we still get HIV medications into people with being able to eliminate that? So we do have injectables now. You know, we currently have one on the market that every 4 weeks you don't have to take pills anymore. You can get medicines that way. That soon will be extended likely to 8 weeks. They're looking at other things from pills that last like a week, so you wouldn't have to do, you know, daily dosing, looking at sub-Q implants, sub-Q injections that would allow patients to do injections at home, eliminate the need to come into clinics. Yeah, so there's lots of ways, and I think this is all kind of in the phase 1, phase 2 kind of trials right now, and a lot of this stuff is also being looked up very heavily in the PrEP world too, to prevent HIV. If we can, you know, eliminate the pill need there and put a little implant under someone's skin that lasts a year, I mean, think how easy that would be. No one would have to worry about forgetting pills, all that. So I mean, I think that's really where the future is how can we take these effective medicines we already have and make it easier for patients. And this, I think, where that collaboration comes in, this is kind of this in real life. Like, we've done the bench work, we know the science works, we know the medicines work. Now how can we take it to the patient and make it work for them? And I think that's the future.
And Dr. Kerkar, I'll give you the same question and preference your comment earlier about how no one is really safe until everyone is safe. And I think in making the advances in HIV care, we are moving towards a more safer community. But what do you feel, or what has your experience seen as far as advances and where we're going in the care that we're providing?
Yeah, I think, you know, the stretch of first cases in the early 1980s to now, you know, nearly 40 years later, it seems that we've come a long way. I do have a lot of patients that have survived the initial 20 years of really toxic medicines, but they took it because we sold it to them. It was about life and death. Now it's about quality of life. So it's no longer about life and death, because we know that not only the diagnosis of HIV need not be a death sentence, that everyone could have the life they were meant to have, or the length of their life with medicine. So it became a disease of chronic management. And as Dr. Foltz mentioned, the advances of better tolerated drugs, better way of, being adherent to the medications, injectables that can be taken once every month. These are things that hopefully will continue to be. And now we will also have a really good hope for having a vaccine with the new platform that is now able to create, vaccines and prevent disease, and not just for infections, but many other things. So I think the stretch over 40 years has accelerated quite a bit to improve life for persons living with HIV. So we are living well with HIV. And now, our goal is to prevent HIV if possible. And I think that process is now accelerating. So I think that the challenges, as many have in parallel increased to our feats that we have achieved, but I think we will still find a way. And, ultimately our goal is to have people believe in science. It is a task, like Dr. Singh mentioned, to explain people who don't understand science, what it is that we are trying to do, what does a randomized controlled trial mean when a medicine appears to work but is really not, and so forth. So these things need to be explained to common individuals that they can understand. But with HIV, the energy of ACT UP and the demand for science to meet their challenges and avoid the number of deaths that could have been prevented, all that was a positive outcome that led to where we are today.
Right.
So that's all positive to me.
Right. And that kind of, ACT UP, and it was so funny when he made the comment, and Dr. Fauci in the movie said, you mentioned ACT UP to a researcher, and it was like, ooh, I'm going to shoot to Dr. Singh as a researcher if she shrills at the name of ACT UP. And what you're doing now in your career, what do you see as advances in HIV care?
If I was in Dr. Fauci's place at that time with ACT UP, I would have probably felt the same way. Just because there was just so much lack of understanding between the two sides. And both sides were trying their best to do what they could do to save lives of AIDS patients, and in their own way and in their own passion. And it was just so interesting to see the disconnect when the objective was the same. And I really feel that Dr. Fauci, when he had that insight, when he realized that there's something off with all this work that is being put in the research and data being collected and trying to come up with therapies for AIDS patients, and why are they still so against all this research and science? They were not against research and science. They were just trying to express that, we need to understand what you're doing and not make us feel like it would take, you guys are taking too long and we have no idea what you're doing in your labs. And that's where the beauty of the insight of Dr. Fauci, maybe a little delayed, but it came. And when he included ACT UP and started attending those meetings, exactly is where the current trials are. The way the trials are designed now, which is why it is so acceptable and so palatable to our patients who participate and contribute to science. And I thank you all so much for contributing to science and helping the other generation of patients and people that are living with HIV, that you accept science when it's presented to you and explained to you in terms that are understandable. And also everything about the trial, when the trial is now designed, this is the new age, if you call, of designs, there are surveys sent out to the patient population. There is data collected. What is even the area where the research is going to be done is decided by patients who are actually experiencing the disease and not by the researchers sitting in their labs. I don't decide what kind of research is being done. I only participate in research and make sure the research is done the right way. Patients decide. And the scientists who collaborate with patients, they decide what kind of research and how it's going to be done, what is better for the patient. If I design a research that nobody's going to be able to participate in, it's a failed research. We have to make sure it is doable. And that's what we tried to do. And I am so thankful that I'm a researcher at this time and not that time, because if ACT UP was to be an organization now, they will have a seat at the table.
Nice, very good. Excuse me. So moving forward from advances to the future. So more recently, the ANAC Greater Palm Springs chapter, Anthony Velasco, our current president, he wrote a piece on HIV Specialist Magazine about the HIV workforce shortages. So in his article, he explained that approximately 23% of HIV providers plan to retire in the next 10 years. And approximately 40% of those who work in HIV care have a difficulty recruiting HIV providers. What are some of the ways we can engage new clinicians to be involved in HIV care? Bridget.
So just looking at it from a nursing perspective and from my experience, we have to reach clinicians at the education level, at the school level. Like there has to be, for me as a nurse, I got a day and a half of HIV teaching in school. That's not nearly enough to cover, and most of that was outdated, by the way. It's not nearly enough to cover the breadth of what HIV is and how many lives it actually really still affects. I think I'm always surprised when people are like, is that still a problem? Because it is still very much a problem. And so unless we can get to new clinicians and scientists and researchers and nurses at the level when they're first coming out of school and get them involved and understand that, this is still something that matters and that's important, we are going to lose them. I remember when I was working at DAP, we had nurses that were coming in their last rotation of school before they took their tests, and seeing the light bulb come on when you talk about the process of HIV and the disease process and how it affects other disease processes that people get affected with. Those light bulb moments are really, really, they're beautiful to watch, and they're important that we somehow translate that into the new clinicians that are coming out of school. There needs to be more taught in school about HIV and what it is, and about how many communities it's actually affecting. And then on that note, we need to get into some of the communities that are affected by HIV, young gay Black men, young Hispanic gay men, Black women. We need to get into those communities and encourage those people to get into school and to go to medical school be it, medical school or nursing school, and get involved in HIV care.
I was watching Dr. Fultz, and I'm going to come to you. What do you think from a seasoned medical provider, interesting enough, from the Midwest, went into this this specialty, which, Dr. Fultz and I are from the same area in the Midwest where there's practically 1 or 2 doctors that will treat this specialty, but yet he went into it. How do you think we can reach future practitioners to come into the HIV realm?
I mean, I think one of the big things too is also really getting more primary care doctors engaged with HIV. I think that's kind of been one issue, is HIV is, because of the advances in technology, it's not quite the level of complexity to treat that it was, 30 years ago. Most people can be very well controlled with 1 pill once a day, and now we're dealing with the aftermath, the comorbidities that come along with HIV, the side effects of medications, we're still learning this in real time as, this surviving group of people who contracted HIV in the 80s are living now to their full lives. So it's really, I think, getting more people comfortable with HIV. I remember when I was doing internal medicine, not even HIV. I mean, it seemed so crazy because of the medicines. And unless you really wanted to do infectious disease or whatever, you didn't learn it to that level. Well, now I think because the medicines are much different and it's less complicated, I think, getting more primary care providers who are very comfortable with doing basic HIV and then, opening up some of these more advanced HIV providers in the ID world to, do some more of the, more complex stuff. I think it's really kind of reutilizing the workforce we have and kind of retraining people, because even what Bridget said when, she was doing her nursing, how outdated that was from what I learned 5 years ago to what I'm doing in real life is very outdated too, from what we learned in our education. So I just think it just needs to start with the education and getting people more comfortable with how different it is to treat HIV patients now.
Right. And Dr. Kerkar, I'm going to come to you again. You've got this long history of treating HIV and being in this specialty where it once was, and Dr. Foltz was saying, where, to take care of these patients, this was something you really had to be the super expert in, where now it's just transitioned to kind of a maintenance. It's like controlling hypertension. What do you think, as a community and collaboration, we can do to get more providers into HIV?
I think, I thought about this quite a bit, because there was an article on Dr. Fauci in the Time magazine, which stated that since this COVID epidemic and Dr. Fauci being in the front and center, the focus was on infectious diseases. And a lot of medical schools reportedly said that, students chose to participate in infectious disease as an option for them for career. I think that each one of us in the medical field, in public health, any area that you might be in, even in technology or anything, that we really need to spend some time educating our younger generation. And thinking back, I wasn't sure what specialty I wanted to go into at my second year time, and I was almost always thinking about going into everything else but infectious disease. But then, the person that inspired me made that decision for me. It was a very, very special event or something that happened. And these things, like, Bridget mentioned, it's like a light bulb. That is what we want to teach the younger generation. We have opportunity every day to affect somebody's opinion about infectious disease, or if it's a medical student or an internal medicine physician or even a primary care colleague who becomes involved in HIV care. I think that it needs to become part of medicine. So we won't need only infectious disease doctors to take care of HIV, but everybody, whether you're a surgeon or a cardiologist or a urologist, that you would feel that HIV or caring for someone with HIV is going to be part of what you do in your own field even. One day that could happen. We all went into infectious diseases and sort of, took care of the bulk, but we also have the responsibility of teaching, inspiring, mentoring the younger generation, whether it's no matter which field they might want to go in, to make them sensitive to and acknowledge that they can participate in the care of that patient.
Wonderful. And then we do have a couple questions from our listeners and watchers. So Dr. Singh, can you discuss the toxicity of today's HIV medications? This is a question from one of our viewers.
One of the topmost concern that most patients are having now is the weight gain. So there is an integrase inhibitor class of HIV drugs that have been implicated in potentially causing weight gain in patients. The integrase inhibitors are the DHHS guidelines #1, frontline standard of care recommended regimen. So basically we combine integrase inhibitors with 2 other active agents, and that's the standard of care treatment. There's a lot of patients who have noticed and reported a weight gain with these drugs. So what I would like to say, yes, there could be a few pound weight gain, but that is something that we hear a lot. And there's been some studies in African countries which have shown that connection, that correlation. That is one of the main toxicity these days, which affects the quality of life for patients too. And then weight gain in other, over time can lead to prediabetes, diabetes, high blood pressure, cholesterol, and just overall poor quality of life. But what I can say that is, once we're mindful of that, once we're aware of that, we can actually learn to combat that by adopting healthy lifestyle and just being mindful of the fact that it can cause it. So I would put this, even though it doesn't sound like a very a big toxicity, but I know it affects a lot of our patients, and it's something that is up and coming. And the pharmaceuticals are doing a lot of research about this too. So that's one of the most common toxicities per se, because otherwise the medications are usually so much better than before. And Dr. Kerkar have experienced all the side effects of these other medications. So I would stop at that in case you want to ask more people the side effect question, toxicity questions, but I would just start with that, but I can go on if you want.
Sure. No, it's wonderful. And, I think medications as they've been, from the beginning to today, I think as far as toxicity, it's not like it once was, right? Dr. Foltz, there's a question here about, can you talk a little bit more about what untransmittable means, the U = U campaign? Dr. Foltz.
Yeah, U = U is the campaign basically that means undetectable equals untransmittable. And this is still a thing that, this has been very pushed out in the HIV community, but in the medical community around, a lot of people don't know this, or lay people don't know this, that if you are living with HIV, you're on medication, it's been at least 6 months and you are undetectable, which means less than 200 copies that we can detect in your blood, that you are unable to transmit HIV through your blood or body fluids, which in layman's terms means, essentially you could have unprotected sex and not have to worry about giving this virus or passing this virus on, which this came out probably right about when I started DAP, I would say, or shortly after, and just seeing patients have that realization that, they can be human beings again, and that they no longer have to fear, I had patients that from like when they were diagnosed hadn't been sexually active with the person ever again and never wanted to be, just because they felt so, traumatized and stigmatized by it. And to see them understand that and me tell them the specific data and how we got to that point and know that, and it's been really remarkable. And I think that just speaks to the advancements of our medicines and how well it's come. And just, it's been like that, and we probably knew that, but just to put it into a word or a symbol, U equals U, and what that means for patients living with HIV and how they can spread it to each other and spread that, that gospel out there that this is the way it is now. And, I think I've seen it be life-changing from a provider standpoint. I can only imagine what it would be like from an actual patient standpoint.
Wonderful, thank you. Dr. Singh, audience viewer said, thank you, Dr. Singh, for your feedback. And, as we're going through HIV transitions and COVID treatments, there's stigma that still exists in our community today. And though despite current treatments available to manage HIV, stigma remains a barrier for many people. Several studies indicate that HIV-related stigma is common even among those who seek HIV preventative services. And this question is for everyone on our panel, and I'll start with Bridget. What would you tell someone watching today or who is listening today who might be hesitant to seek care due to a stigma-related barrier?
So one of the things that I try to remind people when it comes to a life with HIV is that it is your life and your life does not belong to HIV. And so how you move forward in that is largely based on you. Humans are humans, they're exhausting, people are mean, and there's nothing that you can do about that except bolster yourself, because I think that for a lot of people living with HIV, self-stigma and the restrictions that we place on ourselves are much harsher than what someone from the general public can give us. We assume people are going to feel a certain way about us. We think certain family members or certain friends are going to react a certain way when we tell them that we're HIV positive. And it's not to say that there's not negative things that occur with that, but at the end of the day, it is your life and your quality of life, and you have to figure out who you are, who you want to be, and how to be the best version of that. And that includes sometimes facing up to stigma. At the end of the day, if I know who I am, what someone says to me or what they assume they think they know about me doesn't matter, because I knew who I am. And the best way to approach stigma is education. You can try to teach people things. Some people just don't want to learn and they want to stay stuck in that because, hurt people. But what I would say is your best bet for a healthy, productive life that is not one full of depression, that is not one full of anxiety, that is not one miserable, is to get yourself into care, find yourself a circle of people who are where you are. I'm a fan of therapy and group talks, because when you can find others around you that are dealing with the same types of issues and the same things that you're dealing with, it makes it that much easier to deal with. Stigma is a thing, but it's not an insurmountable thing. It is something that you can take charge of and make positive changes so that you can live a positive life, pun intended.
Wonderful. And Dr. Kerkar, what about you? If someone who's listening tonight has a friend or they themselves just might be hesitant to call DAP Health or come to your private practice to seek care because of a stigma, what would you say to them to get them to come to your office?
I think it's very well articulated by Bridget. I can only add to it that, I feel that when you know you need help, you really just need to reach out, because we all are not going to judge. This is what we pledge right from the beginning. our oath is to provide care, period. It isn't based on who you are, what you believe in, which party you belong to. And that, how you communicate matters. It's not easy sometimes to do because a person just won't come to us. But if anyone who feels stigma or feels like they can, you would not be judged based on any of your diagnosis, your race, your religion. That's what I want to say I believe in, I want to communicate to anyone who's listening.
Wonderful. That's so very comforting. And I hope if this is able to reach someone to make that decision to move forward. And we have a thank you to Dr. Foltz for his comments earlier. And I'll ask you the same, Dr. Foltz. You're young practitioner out in the field, and how would you help someone who's facing possible stigma to maybe walk into your office or reach out to you to get care?
Yeah, I think here in California, we're especially spoiled. And I think working at an organization like DAP, even more so, we pride ourselves in being very open. We have gay providers treating gay patients. I mean, all kinds of stuff where we try to make the environment as close to or as comfortable for patients as we are. But I'm also aware, being from Kansas, that is not the way the rest of the world is. And it can be very challenging. I think kind of what we'd said is, I think doing some research, trying to find people that may align more closely or providers that align more closely with some of your beliefs and stuff can be a huge difference, especially in places like that. Finding support groups or isolation to help, bolster yourself so you can get that confidence you need and not be so alone and feel like, you can't go for help, or using those resources to find providers in your area that might be, that might align more closely with you. I think word of mouth is huge here. And I think that really is how ultimately people get over the stigma and get to providers and get to the care they need. Is they just have to take that first step. And I think getting help from other people, using anything you can to get to that step is most important.
Like Bridget was saying, you find your tribe and you hang out together and you get that collaboration. And Dr. Singh, in a research mindset, do you feel stigma might or does inhibit people from maybe participating in research? Not maybe stigma of having HIV, but stigma around what research is or is not?
Yeah, that's a very good question. There's the history of research hasn't been impeccable, as you've seen or heard before. And there were times when, we have a very, very intense consent process now. When we do clinical research, basically we discuss everything. This consenting process can go for an hour. We tell them everything about the research, the good and the bad and the ugly, all of it. And we have just been very blessed with the patients here in the community in Coachella Valley are so eager and so passionate about contributing to science and helping the next generation of patients who will benefit from these cutting edge research that we do at DAP with this new injectables and other new class of drugs that we're trying to bring I have, like Dr. Fultz said, we're a little spoiled here. We have patients that are just so passionate in contributing, and I have not felt that the stigma has prevented them from actually participating in the research or contributing to science. I've actually felt that I wish I could recruit more because, our studies come with limits. You can only recruit like 5 patients on this study or 10 patients in this study, or you can recruit, certain demographics and not certain other demographics. And we're so blessed here that we actually have to turn our patients away from being participating in research. And, It's so blessed we are that we have come from a point where, participating in research for ACT UP or something, other groups that have experienced the other part of research, it was so hard and it was the trust issue. But now, by being so open and including patients from the beginning of the designing of the research, we actually don't see that. Patients are lining up to participate in research, and we're so blessed. And that's why we're able to expand the research department and at DAP, and very lucky to be here and be able to contribute to science in this community.
It's a great position to have your cup runneth over versus being empty. We do have a question about, and I'll lead this to back to Dr. Foltz. What would you say to someone that's living with HIV, but they're hesitant to get the COVID vaccine?
Well, I would probably say the same thing to whether you were HIV positive or not at this point. But at this point, regardless of your disease state, your risk factors, we will never have more scientific sound information about any vaccine in our lives. Never will there be a time when so many people get it across the world and we have data coming in at real time where we can prove what we're doing is safe and effective. This is unheard of, the sheer amount of data and stuff. So, from the science perspective, if it's still being given and it's still safe, and we know that. So, at this point, there's really not. For someone with any specific disease, that may put you at more risk. I think we're 2 years into this now that we know, prevention is everything, because we cannot predict as well as we wish we could, who's guaranteed to get a worse COVID prognosis than others. We obviously know some things, but we don't know others. And at the end of the day, getting a vaccine will dramatically reduce that to a point where, it's not much different than that of a flu or of another upper respiratory virus, or at least your risk of severe disease or death. So, it's kind of reiteration, just giving them the facts, telling this stuff over and over again. I've had some patients that, on the third day they came in, they finally agreed to get the COVID vaccine after trying so many times. So it is daunting work for us to repeat the same stuff over and over and over again, but we continue to do it. If we're not going to stop. We want the best for our patients and the safest thing. I would never give advice that I wouldn't take myself. And just like Dr. Kerkar, I think day 2 or day 1, when they were giving these vaccines out, we were the first ones there getting them. So,
just like in the movie, you show him walk into the NIH, and he rolls up his sleeve and he says, and I wish I could quote him word for word, but to paraphrase him, he basically felt that we as healthcare providers have a duty to set the example and show that this vaccine is safe and kind of walk the talk per se. And I thought that was just so admirable of him. And then, he goes to the room to wait for his 15 or 20 minutes and he goes, I feel nothing. And I just thought that was wonderful. Dr. Kerkar, I'll ask you the same question about, someone living with HIV who might be hesitant to get the COVID vaccine. What words of advice or encouragement might you give to that patient?
Well, I would like to know why, first of all. Sometimes getting to the right advice, you want to understand what the reason for hesitancy is. Obviously, as Dr. Foltz mentioned, over 1.5 billion people around the world have received COVID vaccine, and we're 8 billion of us on this earth. All 8 billion on this earth are susceptible to COVID, HIV positive or negative. And the vaccine gets us some immunity protection, right? Plus, if you survived COVID, there is some additional people. So if you look at the fact that we want to get herd immunity, it would take at least, say, 80% of the population of the entire globe to get, to herd immunity would take 2025. The faster we get there, it's almost like a race between humans and the virus.
Mhm.
Humans have something to hang on. This is the science. And the science of vaccine is not new.
Mhm.
We've gotten major diseases under control and eradicated even. And COVID, we have a vaccine that is upwards of 90 to 95%, preventable of death and disease, ending up in the hospital. So to get to it faster, let's say we shoot for 2023 or 2024, if all of us become immune because we have herd immunity from the vaccine that is long lasting, this is our way to get to beating this thing, because
Not having to wear masks anymore.
and the whole thing is such a ripple effect of all the other things that are going on due to the pandemic. Think of all the depression, isolation, alcohol intake.
There's been reports of
mental
increased
illness,
domestic violence.
domestic
Exactly.
lot of pandemics after pandemics of various different nature, and all the ripple effect on the economy, the whole thing, everything. So what is the barrier? What is the reason for hesitancy?
Right.
HIV or non-HIV? When I want someone to understand first why get vaccine, it's pretty straightforward. I try to tell them why, but I would like to know the person who's asking the question.
Sure. Wonderful. Okay. Bridget, in your view on that same question, so a patient comes in and maybe they've talked to Dr. Foltz or Dr. Kerkar already, and the doctors have explained, like as nurses we know doctors explain, this is a vaccine, this is why you need it, but you come in to give them the wonderful vaccine and they now tell you no, they don't want it, they're hesitant. What would you say to them?
So at the end of the day, I'm not one of those people that tries to force the vaccine on people. You want it or you don't. If you have questions, I try to answer the questions to the best of my ability. I'm fully vaccinated. I'm boosted. In my role right now, what I'm doing is part of what I'm doing. One of my jobs is I go out to patients' homes who are homebound, who can't get out of their homes for whatever reason, and I do the COVID vaccines for them. And it's a predominantly elder population, and they're scared. They have interactions with the community, people that deliver their food when they do have to go out for a doctor's appointment. They're caregivers. And the fact that we have so many people that are not vaccinated is a point of fear for them. And I hate to see them live like that. And I think that people have to remember and recognize that it's not just about you. It's not just about your politics. It's not just about, your idea of what your freedoms are. We're all free. You really have to take into consideration that it's not just about you. It's about a whole population of people who are vulnerable because of the decisions that you make. And so at this point, it's safe. At this point, it's easy to get. Go get vaccinated. I can't force you, but go get vaccinated. It just makes sense to do it.
Okay, and Dr. Singh, the same question to you is, one of your patients, or maybe your patient says, I have a friend or a family member who is just really hesitant to get the COVID vaccine. What words of advice or encouragement would you give them?
I just tell them that, listen, we know what the vaccine can do. I cannot tell you what the infection will do. So it's just safer to get the vaccine. I got it. Everybody in the clinic got it. None of us had those, dire side effects or life-threatening emergencies that has been circulating as a bit of a rumor, or like anecdotal experiences of one patient had one reaction. And it's just, I normalized vaccines a lot in my clinic. It's just you coming to get your flu shot, you're getting a COVID shot, just answer the question. But I normalize the vaccine a lot because data speaks for itself. It's proof is in the pudding. If it was, coming from a scientific researcher point of view too, I mean, I've been following the COVID research, and it's the mind, like Dr. Kerkar mentioned earlier, like how amazing in 8 months that we were able to develop something so amazing and able to save so many lives. Millions of people have got these vaccines. I tell them to look at them and not one or two people who have had bad experience with the vaccine. So again, I know what the vaccine can do. I don't know what the infection will do. Maybe you got it last year and you did not have many symptoms. This time it might kill you.
Right. We do have one question, and I'm not really sure how many might be really familiar with this, but anyone can chime in if you have any information or a recommendation for this person who's listening and watching. They go, what is the outlook on the cost of HIV medication and continued financial support for organizations and programs such as the ADAP program? Now, I know many of the organizations and companies who produce HIV medications, I know they do offer patient assistance programs that do help patients in a financial need. I don't know if any of you have any other inside information or any kind of outlook on the state of support for organizations like DAP and programs like ADAP.
I can speak a little bit to this. I mean, I think one thing that's good that's come out of these pandemics, and that is a major pressure and money inflow of public health of all kinds. So, you saw it after HIV, you're going to see it again after COVID. For the next 5 to 10 years, money is going to go into public health measures to support all kinds of preventable, spreadable diseases. And I think we'll see a little bit of a budget shift where a lot of money and stuff is going away. That is one thing that could potentially help this. But the reality is, yes, HIV medications are extremely expensive, anywhere from $1,500 to $2,000 for 30-day supply. And that's, in this time and age, we shouldn't be having, it shouldn't be that much, and that's a big burden to all kinds of, future treatments, prevent getting this to a point where we can cure HIV. But I think the other side of that too is we live in a great state like California also that puts a lot of money and pressure to keep these programs alive and keep them going because they see the benefit where, less people having HIV is better for the community, better for this or any infectious disease. And it's not always like that in other states and other countries, other parts of the world. So I think that's one thing that's kind of at least a little bit of a plus here in California is that, they do put a little higher priority on that. So that's maybe something a little more protected here, but not the case elsewhere.
It's wonderful. I think, one of the things Dr. Foltz has really kind of led to is geographically, I think how people experience and access HIV care and experience stigma is very geographical in our country. And, I have lived from Kansas as well and have lived there and received care there, which was extremely different than receiving and accessing care here in California. So we are very blessed to have a system that supports all of us, regardless of race, religion, sex, financial status. We all have the equal opportunity to go get the care that we need. We can also, if you need more information on accessing services or need financial support, there are case managers and ADAP workers who can provide more information, and not necessarily just at DAP, but DAP has wonderful case managers and ADAP workers that can help anyone who is listening or watching that can get you the referrals to the services that you need.
Also, just real quick to interject, the other good thing is that we now have an administration who has stepped forward and is walking the walk and talking the talk, that they're recommitting to ending the AIDS epidemic and the HIV crisis. So that's a positive thing. I remember a few years ago, seems like forever ago, but just a few years ago, with the threat to the Affordable Care Act, a lot of our patients have their insurance through the Affordable Care Act and through Ryan White. And those programs are still going to be continuing for the next foreseeable future, at least with the current administration. So that should be a little bit of relief, at least for the short term, and we can continue to work on policy and make our voices be heard, just like ACT UP in the movie. The more noise we make and the more that we talk, the more that they have to listen and hear us, and continue with these programs that really, at the end of the day, are life-saving for people who otherwise wouldn't be able to afford their medication. So kudos to the current administration.
So for our viewers and our listeners, for any questions that we were not able to address tonight, please send me your questions. And once again, you can reach me at gpsanac@gmail.com, and I will be happy to get your questions answered. We are extremely thankful and extremely blessed to have had DAP Health for co-producing our event tonight. This does conclude our program, and I would like to give amazing kudos and thanks to all of our panelists tonight, Dr. Foltz, Dr. Singh, Dr. Kerkar, and Nurse Bridget. And on behalf of the Association of Nurses in AIDS Care Greater Palm Springs chapter, we would like to thank you for attending tonight and for watching FAUCI. Stay safe, everyone, and we'll see you in the community. Good night.
Thank you.
Thank you.